Absolutely. I'm pleased to introduce today's meeting, which is hosted by the School Transformation Committee. It is on unconscious bias by the OIC, it's a regular OIC workshop to presented, but we thought it was a good idea to have a departmental one. So the presenters today will be Undere Deglon, a specialist in institutional culture change, and also Kamakle, who will assist them. Ideally, we actually would like the workshop to be in person. So if anybody that's online could come down to participate in person, that would be great. Because we have a few here, but
can we lock and leave our stuff? Okay. I think that's not a go.
That's on good. Did everybody hear my introduction? So just to repeat, if anybody can come downstairs if they are able to do the workshop in person, because we would like to have it in person because it's more interactive, and I think Andre actually prepared it that it can be in person. So if you are able to come down, that'd be great. So over to you.
Thank you so much. And a very warm welcome to everyone. I just want to introduce Asamathle, who is my co-facilitator for the session. So as Akil introduced us, we are from the Office for Inclusivity and Change. So we report to the Deputy Vice Chancellor for Transformation, Student Affairs and Social Responsiveness. And our work is very much in transformation, diversity and inclusion. Conceptually, how is that different? Transformation is about reflecting the demographics of South Africa, that the university starts to look like South Africa. And then inclusion asks, so once we are in the university, how then do we relate to each other, which starts with personal self-awareness, and decolonization has to happen at 4 levels: at the individual level, at the relational level, the epistemic level, and then on the structural level. So that's generally how our work is organized. We do a range of training offerings. Some of it is on success factors, and that's institutionalized. And then we also facilitate sessions like this, bespoke sessions where we can, as per request by Tumaleng, add healthcare to the traditional offering that we have, which is unconscious bias. What is unconscious bias, the manifestations of unconscious bias, and then most importantly, how do we mitigate against unconscious bias? But for this particular session, this is a unique session because I've been asked to tap into my lived experience as well as my other parts of experience to bring it down to disability. So thank you for explaining that. And yeah, we hope that you will participate freely in the session. When it comes to emotions, feelings, there is no right or wrong. So we very much ask you to participate, right? We learn not by absorbing information, but actually by participating in the information. So now that you know about myself and Asamathle, I'm just going to ask everybody to please just introduce themselves so that I know that you are fully present, physically and emotionally and in voice. Please introduce yourself, and because we have very little time, I'm just going to ask you to share with us one word that either reflects how you're feeling today or something has happened to you today, or you can also reflect on what do you want to learn from today? What is your expectation about today? Curious, I was forced, Akil told me I must come, but only one word because that's the only time that we have. I'm going to start with the people that are in the room. The people that are online, I know that you won't be able to hear them. Should we go around with a Cell phone, or not?
I think
No. Okay, just shout so that people online can also hear you.
I think that's the mic.
Okay, we've got the technology. Then we're gonna start on the left, please.
Itumeleng Takamada for the Division of Occupational Medicine. Excited.
Thank you.
Akhil Dalby from the Centre for Environmental and Occupational Health Research, and I'm also very happy to be here.
One word.
Shaida Adams, Shaida Adams, Division of Occupational Medicine, intrigued.
You.
Edison Cherry, from Health Economics and head of school, hopeful. I'm Hannah Hartigan from the Health and Environment Program, and I think I'm excited to be here.
Colleagues, the brief is one word. We give you a chance to just settle in, so we're gonna go to people online. I'm gonna ask then, I'm gonna start with the people from who I can see first on my screen, which is Mohammed. Mohammed, I'm then gonna ask you to hand over to the next person. So the brief, please unmute yourself, your name, your surname, and one word about that reflects your anticipation or what you expect from the day, or you can also just tell us how your day is going. Mohammed?
Hi everyone, it's Mohammed Chibai and I'm from the Occupational Medicine Division, and my one word is intrigued.
Two?
Over to Alex.
Thanks. Hi, Alex Zuber from the Division of Epi and Biostatistics. Interested.
Alex, who are you handing over to?
Sorry, Maylene.
Hello, I'm Maylene Shanking. I'm from the Health Policy and Systems Division, and I feel pensive today. Handing over to Nandi.
Hi, I'm Nandi Siegfried from the MRC. Hope. Handing over to Griselda Pile.
Hi, Griselda Pillay, Public Health Medicine Registrar. Open. Handing over to, I think this is Barbara. I can't see your surname. Barbara Mapara.
Good morning, good afternoon, everyone. My name is Barbara Mapara. I'm from Employee Relations. I'm here to learn. Hey, thanks. Handing over to Kevin.
Hi, Gavin Regan from the Health Department. Curious. I hand over to Leslie.
Hi, I'm Leslie Landon from Public Health Medicine, and my word is balancing. And I'll hand over to Nina.
Hi, I'm Nina Abrams, used to be Health Policy and Systems, and also feeling curious. I will hand over to Asamakhle. No, not you.
Okay. Then we're going to come back to the people that have joined us. I think we've got three new arrivals. Please, your name so that
I'm in the registered occupation. And are we talking about the topic for today? Just one. Interesting.
Hi, my name is Marcos Artambua. I'm a registered medicine. My one word is capability.
I am Elias Mfuna, I'm the professional medicine registrar. My one word.
Thank you. Thank you, colleagues. Thank you for sharing generously. So we're excited, we're pensive, we're trying to balance, and we're curious. So then let's get started. Unconscious bias in the fabric of society, bridging institutions, healthcare, and disability. So I'm again going to ask you to please join from wherever you are. Please join on your cell phone. I'd like you to join at www.menti.com and use the code 17387972. Please open your browser, join at www.menti.com. And use the code 17387972. So that we make sure that the session is interactive and we co-create the knowledge and the learnings. Right. So the outline of the session for today, what is unconscious bias? Then through reflection, we're going to foster critical self-reflection to help reflection through discussions. We're going to talk about some of the common biases and how they may affect people with disabilities, the impact of unconscious bias on disability by looking at interactions with healthcare providers. So then when we're going to speak about disability, we're going to speak about the individual level, the community level, the institutional level, and then we're also going to speak at the systemic level. And then the last session, what are some of the strategies that we can use back in our own environments as we leave this afternoon to address or mitigate against unconscious bias in healthcare? So you are already participating. So the first question I'd like you to reflect on, have you ever felt that someone judged you solely based on a preconceived stereotype? Have you ever felt judged based on an idea, a stereotype, a perception somebody had about you that was quite divorced from who you are as a person? 12 people say yes. 14 say yes. Luckily, this is not a maths class because I can't calculate how many people there are here and how many people there are. So I'm gonna then, I feel like we are standing still at 15. So 15 people here say that they felt judged, right? So then, based on that experience, looking at the people in the room, what would you say is a concept of unconscious bias then? What do you think? How would you define unconscious bias? If a 4-year-old or 5-year-old had to ask you, what is unconscious bias? Jumping to conclusions, thank you very much. Favoritism. Making assumptions, predetermined ideas. Unintentional. Judgment. Predetermined ideas, jumping to conclusions, having assumptions, making assumptions, misperception, taking for granted, ignorant, jumping to conclusions, learned prejudice, ingrained prejudice. We have 15 people, we're just waiting for 3 more. Judgmental. Okay, so let's then, thank you very much to the 15. 16. Akil will be handing out prizes. You're the one that participated anonymously. Mental shortcut. So then my work is done here. Thank you very much. See you for the next section. Okay. So I'm going to move on just in terms of the time. Please continue participating. 21. Yes. Okay. So what is unconscious bias? What does the theory say? So the theory says that unconscious bias is a learned stereotype, a learned prejudice in favor of or against something, some individual, or a group of people based on learned mental models that we've acquired from a very young age already. So the field of neuroscience, developmental psychology are actively contributing towards our understanding of how it shapes us at an unconscious level. So there are two types of biases. We have conscious biases. We know, we are aware of it. We're trying to mitigate it. We're having conversations with ourselves. But there are unconscious biases. Unconscious biases are those that are quite in opposition to our values. So I might have a value of being committed to social justice. But when I am, and then we also know that the circumstances under which we are most likely to act out our bias is when we're under stress, when we have a deadline, you know, then that is when we again revert to the quick snap judgments that we've learned over the years and we've been socialized into about individuals, about people who look different to us, who sound different to us, and so on. Another school of thought suggests that each of us, as we sit in here, each individual has a particular matrix within us, a matrix of who is safe, familiar, comfortable, and that when we are come into interaction in a situation where we are engaging with someone who's outside of that matrix, that's again when we revert to not safe, not familiar, not comfortable, and all the subsequent inferences that we then make based on individual identity markers. So we most likely have the diversity traits that most likely that we know a lot about is the visible diversity traits, right? Race, ethnicity, nationality, age, physical ability, and gender, sexual orientation, gender identity. So the diagram that you see here is called the bias iceberg, because we most likely, when we come into a situation, that's what we see. We don't know that somebody has, the other things are below the surface. So we don't know so much about people until we become familiar with them and we start to have a dialogue. But coming into a room, coming into a conversation with somebody, immediately we make inferences about race, ethnicity, nationality, physical abilities, age, and so on. In agreement? Are we all together on this one? Now, bringing it back to the conversation we're having today, it's important that we understand how these different identity markers also can compound in terms of intersectionality. So if I come into conversation with someone and I already have a preconceived idea about race, how much more if we add gender? How much more if we add disability? then the prognosis is not very positive in terms of how we're going to, in terms of our equitable, how we treat, how we behave, the decisions we make, the decisions we don't. So what starts as a oversimplified stereotype mental model about the world becomes, which is a widely held preconceived and oversimplified image or idea about a person, a group, or thing, over time becomes unconscious biases. Unconscious bias is an automatic association or attitude about race, gender, disability. It operates outside of our conscious control. It leads to prejudging. It then leads to, so the first three is still happening at the conceptual level. But then when we start to act, when we start to behave, then now we are firmly into the realm of discrimination, harassment, racism, ageism, and all the other discriminatory behaviors, right? So the last two, behavior and discrimination, that's a doing word. But we now show the progression from what started as a simple model, but then actually leads to discrimination. A little bit more about conceptual understanding of bias. Our brains use two thinking systems. System one is responsible for the quick decisions we make. System one enables us to drive a car without thinking too much, or make a cup of coffee without thinking too much. Whereas system two is more monitoring and evaluatory. We make more conscious decisions, we reflect, and so on. So if we understand that at every day, in every action that we take, we are employing these two systems of thinking. And the key objective of today is that we reflect on unconscious bias, that we understand how it works, so that we start our journey towards working towards mitigating those kind of behaviors. So biases over time, if left unchecked, become wired within the brain. It creates a system of systematic thinking, and they are learned through culture and experiences, so they are contextual. We know that they are, because they are contextual, therefore they are socially constructed. So I have a stereotype about a particular group. So, similarly, that person might have a particular stereotype about my group. Right? So if we look contextually at a map of the world, that we have different types of socially constructed, what is desirable, what is acceptable, what is safe, what is familiar, what is what is acceptable. And the positive thing is anything that is learned can be unlearned with conscious interaction, with engaging with it. Then this is a speed test. I'm going to ask you, can you all see, please, which concept do you associate with this image on the screen? Using your menti.com. Quick. Religion, your choices are religious, playful, lazy, professional, frivolous, athletic. In the interest of time, I'm going to stop there. The interesting thing about this exercise is by the second slide, people understand what is happening, right? So somewhat the data by the second time is not as authentic as it would have been. Yeah. So then I'm going to stop there. So your choices are athletic, professional, lazy, dependent, frivolous, religious, all of the above.
It's Mohammed here. Could I ask a question or make a comment?
Yes, please.
So I would have liked to have ticked more than one of those characteristics, but the system doesn't allow me to do that.
If you look in the last one, it says all of the above. Oh, you mean more than one, but not all of the above?
Correct, yes.
Thank you so much. That's what we look into that. Definitely change it to the next. Colleagues, in the interest of time, the exercise is really just intended to show, illustrate that often we do make. There's a self-judgment. You know, if we even look at this slide, athletic, is it not possible that this person could be athletic, professional, lazy, dependent, frivolous, and religious? Doesn't look lazy. Maybe he's just wearing the clothes. What if he's a model and he was asked to sort of lazy? Do you know what I mean? I think the point or the illustration, what I'd like to illustrate mostly, is that when we come into a conversation with each other, we bring our full selves, right? And we are professional, we are ambitious, we are religious, it can be and. The conversation is about and, not either or. It's about yes and no. Yes and yes. Moving on. So then let's look a little bit more closely around how unconscious bias affects people with disabilities specifically, and specifically then looking at healthcare provision. So the basis and the statistics for this conversation is a report by WHO titled The Global Report on Health Equity for Persons with Disabilities, which is quite recent, 2022. So the statistics are also quite recent. So it starts off with a quote: of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. It's a quote by Dr. Martin Luther King. So some of the key points in the report. In 2021, an estimated 1.3 billion people, or 16% of the global population, experienced some sort of disability. This number continues to grow because it is driven by the increased number of people with non-communicable diseases, and people are also living longer and aging with limitations in functioning. But we also know that it is rising as we're sitting here, specifically in countries where there are wars, in countries where there are conflicts. Many of the differences in health outcomes between persons with disabilities and those without disabilities, according to the global report, cannot be explained by underlying health conditions or impairment that are associated with, or impairments that are associated with avoidable, unjust, and unfair factors. And these factors are then called health inequities. According to the UN Convention on the Rights of Persons with Disabilities, of which South Africa is a signatory, it is an ethics, Article 25, obligates the state, obligates the South African government through the healthcare sector in coordination with other sectors to address existing health inequities so that persons with disabilities can enjoy the inherent right to the highest attainable standards of health. The obligation is an international law of human rights. And just taking out some of the key points, the differences between a person with a disability and a person without a disability can be seen in three key indicators: mortality, morbidity, and functioning. So then would it be acceptable to say that having a disability is a social determinant of health, number one? Having a disability is a social determinant of dying. If differences can be seen between persons with disabilities and non-persons and persons with non-disabilities in mortality, so having a disability can actually influence whether you get the appropriate health care at the right time, and if not, then that the consequence of that could be death. Mobility and functioning. And then, what do we know about the people with the disabilities? Nearly 80% of the 1.3 billion live in low-income countries and middle-income countries, as opposed to 20% in high-income countries. However, the prevalence of disability is highest in high-income countries and lowest in low-income countries per capita. Further, inequities arise from unfair conditions, and then it makes reference to the structural factors, which brings us then to how it affects outcomes as part of the fabric of society, the socio-economic and political context and the mechanisms, the social determinants, the conditions in which people are born, grow, live, work, and age, and the risk factors, as well as the health systems. The barriers across all these different areas, then in service delivery, the health and the healthcare force, health information systems, and the financing, as well as the leadership of health systems. So let's then look specifically at South Africa and the kind of world for a person with a disability in South Africa, in a particular community. And here is a representation of, as we know, South Africa has the highest Gini coefficient in the world, which makes us the most unequal country in the world. So if we then look at inequalities in health care and many others, including education, and so on, this image particularly is an image from Lake Michelle, which is in the Noordhoek area, and then Masiphumelele, which is just across the road, across the green rolling fields. And this brings us then around structural biases that emanates from the structural, at a structural level. And what this kind of reality then looks like, how that then translates into a person with a disability from Lake Michelle compared to Masiphumelele. Looking at Masiphumelele, we know, let's take the example of someone that is someone with a disability that's giving birth in Masi, and there's some complication that needs to get to a hospital. What is the implications for access? Number one, as you can see, there are no roads. I very much doubt that you'd be able to call an ambulance. All things being fair, so the ambulance is called, the person gets to the hospital, and the hospital is the local mobile daycare clinic that operates. And the kind of healthcare that is accessed by that particular person. And then let's overlay that. So that's socio-economic conditions and everything. Let's overlay that then with a person with a disability, a woman with a disability, a woman in a wheelchair, giving birth in those kind of circumstances, then gets to the mobile clinic for care and the kind of care that it can be accessed if there are no proper tables, no access, no proper facilities. And this then is the reality that we live with every day in South Africa, isn't it? So let's then take it a little bit further. So the woman gets to the mobile daycare clinic. What kind of, and then has complications? Is it in that moment that a decision can be made whether she can get the appropriate care or the system is just stacked against us? And the decision is then made around. Itumaleng, may I? You're nodding.
So I think from my side, I was actually thinking about it from the reception point of view, that it doesn't only end with struggling to get out of the actual informal settlement, but it also is the reception that one gets when you get to maternity, and depending on which side of the lake you're from, and what kind of reception one gets, and the kind of treatment one gets. There's another layer that one has to face as a patient.
So then this is a slide from Professor Salome Maswine. It's much more important then to know what sort of a patient has a disease than what sort of a disease a patient has, right? And really where the patient comes from.
It's like maybe short case.
If we just go to the technical issue. Wow, so good to joy. Colleagues, I just want us to please work through the case study. It will take people individually much shorter. So we're going to use the next 5 minutes. It's now 12:45. We'll resume in plenary at 12:50. I'm going to read to you the case study that I'd like you to reflect on here. Ramonda is a 28-year-old woman with cerebral palsy, affecting muscle coordination and body movements. She's a wheelchair user and communicates with the help of a speech generating device. Despite her disability, she's an independent individual with a master's degree in sociology. Colleagues, can you still hear us? We're back, right?
We've been having some difficulty. We didn't hear the case study. Perhaps you can post it in the chat.
Can you still see the presentation?
No, we can see Simpiwe.
Eyes, wheels, yeah. I'm thinking. Yeah. Okay, can you see the case study then?
Correct. Yes.
Yeah, there we go. So we've now moved towards what are some of the strategies you believe you could use to mitigate against acting in an unconscious biased way? We'll be back at 12:50 for reflection. Colleagues, time is not on our side. Time is not on our side. So I'm going to give 1 minute for wrap up. And we can then ask the groups that are in the room to come to reflect on case study 3 and 4. But to the people online, I wonder if anybody tell us what they thought, what are some of the risk mitigation strategies that they thought about? Is there anybody who would like to volunteer? Yeah, would anybody like to volunteer or should I volunteer? We just Leslie, please proceed. Thank you.
So I just had one observation from my experience is that communication is so important, and when you automatically assume a person you're engaging with can't communicate, you immediately shift your gaze to the person who's translating or acting on their behalf. And I was struck by how the vignette included that immediately the healthcare provider is related to the child when the person is quite capable of communicating, though in a different way. Happens with the deaf, it happens with others. And I try and consciously try and focus on the person, even though I have no idea what they're saying. But I have to rely on a third person to translate for me or to articulate it for me.
Thank you very much, Leslie. I'm going to come back to that. That was very helpful. Thank you. Anybody else want to contribute? Carmelita, Nina? Maylene, please go ahead.
Thank you very much. I think I obviously appreciate the issues that Leslie raised. When I read through the case study, two things also struck me is, and this goes from my time as a practitioner, that I think people communicate with the one they feel most comfortable with in that moment. So I could speak reasonably okay, conversational closer, but many of the patients defaulted to talking through to the interpreter that were always next to us instead of directly to me. So sometimes it could not necessarily be about unconscious bias as such, but just but not, of course, in this instance. I think in this instance it was quite problematic. But the second thing is it's not uncommon for doctors to unfortunately focus on the thing that they feel is important versus what the patient really came to complain of, and that it might not always have to do with the fact that the person has a disability, but just the fact that we just have massive blind spots on all kinds of things. I remember a patient that had a huge growth, but she came for a problem with her vision, and everybody ignored her visual problems and focused on the growth. So I think there's also some common things at play that might or might not necessarily always have to do with a disability bias in this instance, such as in this instance.
Maylene, you definitely raised a very valuable point. So just to go back to what Leslie raised, I think for me the key in Leslie's feedback was conscious, right? That you consciously make a decision that you're going to pay attention to the full person. Colleagues, time is not on our side. It is 12:46 and we're going to start losing people. So I'm just quickly going to ask one group in this room. I'm going to choose a Tumaneng. Tumaneng, please can you reflect back to us some of the strategies you decided
on? So we kind of answered the questions. We didn't.
Do you want to please come present here so they can also hear?
So our case with a young lady in a wheelchair basically went to a doctor for contraceptive advice, and instead was sort of given a counseling session on sexual capability as well as the ability to give birth, raise a child, etc. So we thought consequences of the interaction were that that the doctor didn't really engage in the patient's concerns, that she immediately felt uncomfortable because she raised that she observed a change in the doctor's attitude in the interaction, and that whole engagement was not patient-centered. And maybe it comes back to Maylene's point that as doctors focus on what we think is important rather than listen to the patient. And in her case, it's probably made worse by the fact that she's disabled and in a wheelchair. Then how could the doctor's failures to provide information on a range of contraceptive methods affect inability? Because the doctor basically just only on one method and just by the way said this is what you should consider. So I think it limits the choices for the patient, and And the patient could end up with the wrong choice because they weren't really counseled, and choosing a contraceptive, it's not just about the contraceptive itself, but what's your lifestyle and preference. And even with the choice that was presented to her as the sort of go-to contraceptive, we don't think she was really given much information to make an informed choice about that. That's kind of how we go.
Thank you. Thank you very much. Colleagues, we're going to then, in the last 2 minutes, if people do have a few minutes, please, I ask you to stay. So there we've heard that some of the strategies that we can use to mitigate, but I'm going to offer this particular model. As I started the conversation, I said that we are most likely, even if we have a value that says I commit myself to providing equitable health care, we are most at risk when we are overworked, when we are tired, when there's a long waiting queue, when there's a taxi strike, and all of the factors around us are quite tumultuous. But I encourage you to in those circumstances, particularly to become more mindful of your behavior, compromised behavior. So the first, this is called the Space 2 model of mindful inclusion. Space 2 because it starts with SPAC and then 2 E's. So it's easy to reflect back, right? I hope in that moment you'll hear this presentation. Space 2. Slow down. Right? Slowing down, taking the time to process and reflect on the other people's responses and what you are about to do or do not do, and the impact they are. Perspective taking, showing empathy towards other people's identity and beliefs. You know, the one thing about all the different diversity characteristics that we talked about, race, gender expression, gender identity, disability is one thing that can change at any minute, right? Today, I do not have a disability. Tomorrow, I might have a disability. And as we get older, we become, the probability of us acquiring disabilities later on in life becomes much higher, right? So being able to put yourself in the other person's shoes. Asking yourself, am I making, when you're writing that diagnosis, when you're writing the treatment plan, when you're doing the research, and you ask yourself, am I really covering all my bases here? How cultural intelligence, becoming aware of other cultures, behaviors which differ from your own. In terms of cultural intelligence, I'm offering to you the difference between the medical model, where the person with a disability is pathologized and seen in need of pity and fixing, and the healthcare provider is the fixer, versus the social model. The social model says we know we have an impairment. Yes, we have an impairment, but it is the environmental, the attitudinal, the unconscious bias behavior that further disables me. It's the poverty that disables me, not, for example, let's make an example. We spoke a lot about people in wheelchairs. It's not the spinal cord injury in that moment that's disabling me. Yes, the impairment is there. Then exemplars, challenging the stereotype by interacting, getting to know other people that are outside of your stereotype, right? If your stereotype is that people with disabilities are not valued, then challenge yourself by perhaps interacting with them. I know this is difficult in the face of healthcare challenges that we are experiencing in South Africa. But if we look ourselves in the mirror and we say we are committed to equity, we are committed to transformation, then it needs to translate into actions as well. Expand, surround yourself with other cultures. So that's in terms of strategy. And I'm really rushing through it. I will share the presentation with Tumalek and with Akil for people. I have a range of resources that I can offer for further learning. I just want to end the presentation here. I'd like you to look at these two men. These are my two children. Their names are Matthew and Ray. So a little bit about myself. I acquired a disability because of a traumatic car accident in my late 20s. And there I was trying to put my life back together and, find a job. And my fiance asked me to get married. So the first thing I did is I went to my gynecologist and I said, I'm thinking of getting married. Can you please give me contraceptives? And the gynecologist looked at me and it was a he. He said, the chances of you falling pregnant is so slim. I remember him holding the x-rays of the spinal cord. I have a spinal cord injury. Holding the x-ray of the spinal cord injury up in the end and looking at me and saying, the chances of you falling pregnant because of the extent of your injuries are so slim. I wouldn't bother about that. But let's talk about how you can transfer from your wheelchair to the bed and so on. So there I was, got married, and exactly probably 8 months and a half later, there was Matthew. I had Matthew, went back to gave birth, then tried to be a good mother, went back to the gynae, he said, can you please give me contraceptives? And he said, but you're breastfeeding, I'm sure it will be fine. Exactly 18 months later. I mean, who has a child 18 months later? 18 months later, there was rain. So I know the impact. Fortunately, my socioeconomic conditions allowed for me to raise them. Fortunately, those were the mitigating, factors, the protective factors. And Matthew got married 3 months ago at the age of 23, and Rain is doing very well, thank you. So there's a happy ending to the story. But, those are the kind of, what I am hoping for is that it starts a process for you on self-reflection, on the kind of, what are our unconscious, deep unconscious stereotypes that we might hold about other people that are completely divorced from reality and is in no way linked to the truth at all. So colleagues, I'm going to stop the presentation there. And then I just have please, I have to ask that you do a quick evaluation of the session. Colleagues, I need to ask permission from the room if we can continue. It's already 13:06. Can people still continue on a little bit? I see there are some questions. Are you still okay to continue? Maylene, I think you had a question, and Leslie.
No, sorry, my hand isn't up. It's a mistake. But thank you so much for the wonderful session and for sharing your story with us.
Yeah, and mine was just a thumbs up to say I'm happy to stay a bit.
Colleagues, then I'm just going to ask you, let's go back to the presentation. There we go.
Maybe just opinion from the school. I would say thank you for an excellent session. I'm really impressed how you compressed your 2 hours into one session, and also dealing with online, and I was a bit worried when you asked me for the table and the table, but I think you did great. It's very thought-provoking and lovely. Very nice session. Very good. Thank you very much.
Thank you so much. Thank you so much, Akil, and thank you to Malene. Thank you, colleagues. Thank you for having us. Thank you for sharing with us and sharing generously. We really enjoyed the session. And if ever you need, please invite us back. We are always willing to come back. Please, would you share some of your key takeaways from today's session, and then I will send the presentation as well as the resources as I promised. Thank you very much.
Is a workshop. Better been advertised.
So then from our side, thank you very much to everyone online.
No, thank you. Thank you.
Thanks Leslie, thanks Nandi, Kamlita, Richard. Hope you have a lovely day further.
Thank you, everyone.